onset sepsis. I'm Valerie Garrison. I'm the Director of Initiatives and Engagement with the Colorado Perinatal Care Quality Collaborative. So just a couple of items of housekeeping. This call is being recorded, so please stay muted during the presentations. You can use the Q&A button on your options bar to ask questions during the presentations, and we will discuss those questions at the end of the webinar. If for some reason we don't have enough time to get to all of your questions, we will definitely follow up when we send out the recording as well. So our agenda for today is we're going to give you a brief overview of neonatal early onset sepsis in term and late preterm infants. We're going to share a success story from one of our partner hospitals. We're going to orient you to our new web-based toolkit, and then we'll go through some examples to show you how to implement and practice the sepsis risk calculator and examples of how this has been applied at St. Joseph Hospital. So with that, I will introduce Jamie Cabrera, who's the Executive Director of CPCQC.
Thanks, Valerie, and thank you everyone for being here this afternoon. We wanted to just share a little history before we dive into the wonderful content that you'll all be seeing today. In 2015, the CDC and the Vermont Oxford Network launched a collaborative quality improvement platform for antibiotic stewardship in newborns, and that was called Choosing Antibiotics Wisely. And our state, Colorado, formed the Colorado Antibiotic Stewardship Collaborative. And that's a statewide collaborative that included 17 Colorado hospitals participating in the initiative. When the Choosing Antibiotics Wisely initiative ended, many of these CASC hospitals continued their work to reduce unnecessary antibiotic exposure in our hospital newborns through the CASC NEOS initiative. The CASC NEOS Steering Committee developed this toolkit for hospitals that would like to implement their own neonatal early onset sepsis quality improvement initiative. This toolkit is designed to support teams through a self-directed quality improvement project. It includes tools, tips, and valuable lessons shared by our collaborative members. And before we dive in, I want to say a special thank you and introduction to our CASC NEOS Steering Committee, who has dedicated countless hours, and I do mean countless hours, over a number of years to really pull together these amazing resources that we're sharing with you. First, we have Dr. Bobby Chambers-Haw, who's a neonatologist from Banner Health, North Colorado Medical Center. We also have Tracy Heberlin, a neonatal nurse practitioner with Banner Health, North Colorado Medical Center. She's also one of our original members of our collaborative in Colorado. We have Dr. Jeff Homan, a pharmacist with UC Health Poudre Valley, UC Health Greeley, and UC Health Medical Center of the Rockies. We have Dr. Mary Laird, a neonatologist with Children's Hospital Colorado, Colorado Springs, and the UC Health Memorial Hospitalist at Parkview Medical Center. We have Carrie Montgomery, who's an RN, BSN, MSOL, and Director of Women's and Newborn Center at Platte Valley Medical Center. We also have Melda Music, our neonatal nurse practitioner from Children's Hospital Colorado and Platte Valley Medical Center. Our pharmacist, Scott Sviem, with the CASC NEOS, he's representing us as the vice chair, and also with St. Joseph Hospital from SEL Health. We have Dr. Pamela Zacher, neonatologist and CASC NEOS chair as well. So thank you again for your dedication, your passion, and your commitment to this project. And we're so excited to hand this over to dive into the details of the content here.
Hi, I'm going to start us off with an overview of antibiotic stewardship for neonatal early onset sepsis in term and late preterm infants. Next, I'll spend the next few minutes talking about early onset sepsis, antibiotic stewardship in the context of newborns, and I'll go over some recent past guidelines and the most recent guidelines for evaluation and management of babies who may have sepsis, and then I'll do a quick introduction of our toolkit. I wanted to focus, or to really focus on the fact that we are talking about babies 35 weeks and up. There are very significant differences in incidence and risks for preterm babies with early onset sepsis. The broad and much simplified definition of sepsis is organ dysfunction caused by infection. Next slide. But early on, oh, sorry, back up one more. Early onset sepsis specifically is diagnosed in babies who have blood or a cerebrospinal fluid culture obtained within the first 72 hours of life growing a pathogenic bacterial species. EOS is by definition acquired by vertical transmission and not nosocomially or community acquired. And then one more point about that with regard to the clinical diagnosis of sepsis in general, 80 to 100% of babies who have a positive culture will have or go on to have clinical signs of sepsis. Okay. Vertical transmission occurs when vaginal or genital bacteria ascend during labor, or most especially after rupture of membranes, or as the baby passes through the birth canal. A much less common cause of EOS is hematogenous transmission, where bacteria in the maternal bloodstream crosses the placenta. And while this is rare, it's usually quite severe. It's the most common organism that it's associated is with Listeria. Most common organisms that cause EOS are the same ones that we've all been learning for years: Group B strep, E. coli, and other gram-negative organisms, and Listeria. This figure here shows data on term and preterm infants, so this includes preterm infants, from 1990 to 2008. And the blue line represents early onset sepsis. And you can see that there is a precipitous drop in the incidence of early onset group B strep sepsis that began in the early 1990s. The interventions that were started then and kind of accumulated were nearly universal screening of women in their late pregnancy for group B strep colonization, and then a more standardized approach to treating with prophylactic intrapartum antibiotics every woman who was colonized, as well as women with evidence of intrauterine infection, also known as corium neonitis. The incidence you see there of 1.7 per thousand live births in the 1990s has decreased to a stable rate of around 0.22 per thousand live births in 2016. Next slide. This graph picks up a few years before the prior one left off and ends in 2014. This data set is also made of preterm and term infants, and we can see that the rate of group B strep infection remained low after the other chart left off, and that the rate of all causes of early onset sepsis is under around 0.8 per thousand live births. Again, preterm and term infants. And then click again. The CDC estimates that overall in the United States, 0.5 per thousand live births are associated or affected by early onset sepsis. And to put that in perspective, think about how many deliveries you have in your own delivery center, and say that's 2,000, and most of those are term babies. You'd estimate you'd have on average one event of sepsis per year. We don't know exactly what our rate is in our individual hospitals. You have to really have a huge number of patients to figure that out. The rate of sepsis does vary by region, but in general, we look at that 0.5 per thousand live births. And click again. So in general, sepsis in term babies is a very rare event, but we wouldn't even be talking about this if it weren't a serious event for the babies affected. Most babies who have sepsis go to the NICU, and there's about a 2 to 3% rate of mortality for those babies. And one last point for this, while we're talking about, that's okay, while we're talking about this, is that we use a lot of antibiotics trying to head off those adverse outcomes for babies who may develop sepsis. And next slide. Which leads us to talk about antibiotic stewardship. And I'm going to read here, according to the CDC website, antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. They go on to describe that, quote, antibiotics have transformed medicine, making once lethal infections readily treatable. And next slide. But they warn us that 30% of antibiotics or more are prescribed inappropriately or unnecessarily, that patients who receive antibiotics are at risk of serious adverse events, with Clostridium difficile being one of several examples, and that those of us who are not receiving antibiotics are nevertheless at risk of complications from antibiotics, for example, and most specifically, really antibiotic resistant organisms which develop from related to antibiotic exposure. Next. This graphic by Roche Diagnostics illustrates the prediction that without really significant changes, infections with antibiotic resistant organisms could become the leading cause of death in the next 30 years. Newborns are at risk of the same problems as adults are of antibiotic exposure, but they have some specific risks. For example, preterm babies who receive extended courses of antibiotics after birth are at increased risk of developing necrotizing enterocolitis, which is a severe life-threatening complication for premature babies in the NICU. And children who receive extended or frequent courses of antibiotics in their first year or two are at risk of later development of obesity, wheezing, and allergies. Next slide. This slide just reminds us that antibiotic exposure is one of many that affect the intestinal microbiome and may increase, again, the risk of allergy, autoimmunity, and obesity in childhood. Next. So to summarize, early onset sepsis in term and late preterm infants is rare. Antibiotic overuse and misuse has serious and potentially lifelong consequences, and it's imperative that we improve our ability to identify babies at risk, monitor and screen effectively, and treat with the right antibiotics for the right amount of time, which includes sometimes treating with antibiotics babies that we do not know for sure yet have sepsis. So that leads us to the evidence-based guidelines. For, probably throughout humanity, people have known that certain perinatal factors really increased the risk of sepsis, and they probably didn't call it sepsis, but death for newborn babies. And then with the advent of antibiotics, doctors were able to identify, for example, babies who'd had very prolonged rupture of membranes and treat empirically with antibiotics. Over the last few years, guidelines have attempted to really further characterize the risk that the perinatal events may be associated with sepsis, and with all good intentions, have also guided the use of antibiotics for those at highest risk. As it turns out, the most recent past set of guidelines have probably contributed to really a vast overuse of antibiotics, resulting in exposure of many more babies who than just those who turn out to have sepsis. And next. On the left category, on the left column there, you'll see that there is a set of guidelines from 2010 to 2012 that began with the CDC guidance in 2010 with further clarifications and simplifications through the 2012 guidelines. All of these guidelines recommended laboratory evaluation and empiric antibiotics for babies whose mothers had been diagnosed with chorioamnionitis. and CBCs and other labs, including cultures on some of the Group B strep exposed newborns as well. And these recommendations were made with the understanding that, or the belief at that time, that 90% of babies with sepsis had been exposed to chorioamnionitis. As it turns out, with newer data, at least 50% of babies who develop sepsis do not have a mother who was diagnosed with chorioamnionitis. And somewhere around less than 1% of babies whose moms had chorioamnionitis actually develop sepsis. So somewhere between tens of and hundreds, and it's likely hundreds with those guidelines of babies are exposed to antibiotics for every truly septic baby. So click again. So rates of sepsis are lower than they were, probably even from the database that those guidelines are based on. The diagnosis of chorio can be subjective in a neonatologist's view. Electronic health records have given us access to just massive discrete bits of data that can help us further suss out really risks of infection. And oh, by the way, laboratory evaluation such as CBC has turned out to be remarkably non-specific, and certain lab evaluation is no longer recommended as it used to be. All of this leads to timing for a new way of determining which babies are at risk and what to do with them. You're going to hear a lot about the sepsis risk calculator in the next few talks, so I'll just talk about the last 3 points. The SRC predicts which babies are very unlikely to have sepsis, reduces the use of antibiotics. The recommendations reduce the use of antibiotics and results in fewer lab draws. Okay. In 2018, the AAP and 2018, the Committee on Fetus and Newborn came out with their long-awaited guidelines. Next slide. And the most anxiously awaited piece of the guidelines was, what were they going to tell us about how we should risk stratify or determine which kids were at the highest risk? And click again. The recommendation is that birth centers, not individual providers who work in large groups, should look at these three options and develop their own locally tailored guidelines. And they said we could use the old guidelines, we could use the sepsis risk calculator or other tools, or we could just watch babies closely to see who was getting sick. Click again. And the sepsis risk calculator is certainly endorsed by a lot of bodies. I'll be talking about these other recommendations from the 2018 guidelines briefly in the next slides. Next. The link to the sepsis risk calculator is at the top of the slide. I just want to emphasize that the calculator was validated as low as 34 weeks gestational age. The AAP is very clear about the dividing line of 35 weeks, because the risks, again, for preterm babies of sepsis are so much different. The link on the bottom of this slide will be on the PDF and goes to how the sepsis risk calculator was developed. Next slide. And you can go to the next one. You'll be seeing that again. The antibiotic usage rate, or how many kids get antibiotics, is much lower when the sepsis risk calculator is used compared to the 2012 guidelines, leading to the very reasonable question of whether or not babies who should have gotten antibiotics and would have been helped by early antibiotics was lower or inappropriate with the sepsis risk calculator. The long story short from these two meta-analyses is that the antibiotic usage rate was lower, and that there were not missed cases of infection with the sepsis risk calculator, or that they were at the same rate as the prior guidelines. Next. The 2018 guidelines also also remind us to always get a blood culture, use a minimum of a milliliter of blood, and that intrapartum antibiotics do not invalidate the newborn's blood culture. And this is important, and it's actually different from guidance from a number of years ago. Next. Ampicillin and gentamicin are still our first choices for empiric treatment, and we should be discontinuing antibiotics if our blood cultures are sterile by 48 hours earlier in many circumstances. And it's unusual to have a need to continue antibiotics if the cultures are negative. We very rarely anymore diagnose pneumonia, and we should certainly be documenting a reason for continuing antibiotics longer after 48 hours if our culture is negative. Next. Antibiotic dosing per LexiComp. All of the print and online resources that I've checked recently have updated dosing. Next. You'll be hearing more about AUR, or antibiotic utilization rate, which is a way of normalizing or comparing populations for antibiotic exposure. Next. And this run chart came from the newborn nursery at my hospital, Memorial Hospital, after we introduced the sepsis risk calculator. I want to point out that we also, in my practice, use the sepsis risk calculator in the small NICU at Memorial and our larger neonatal intensive care unit at Children's Hospital in Colorado Springs for appropriate babies. But the takeaways are that our antibiotic utilization rate dropped after we first just started talking about the sepsis risk calculator, and then after we formally implemented it, and that there was a higher rate and a wide range in antibiotic utilization rate prior to the sepsis risk calculator, when we were ostensibly all the pediatricians were using the 2012 guidelines. It turns out that many were not giving antibiotics to all chorioamnionitis exposed babies. That was, in retrospect, probably medically appropriate, but gives the risk managers at the hospital the heebie-jeebies, and is also probably a medical risk when we don't apply a guideline uniformly. Next slide. I'll talk briefly about the relationship of these two entities. Next slide. The purple circle there is CASC, or Colorado Antibiotic Stewardship Collaborative. That's us, people who are talking to you on this webinar and have put together the resources for this toolkit. We worked with Vermont Oxford Network, which is an international quality improvement and benchmarking organization. We worked with them on antibiotic stewardship, and we're tasked with bringing antibiotic stewardship and the sepsis risk calculator back to Colorado. Next. Our work started off as a collaborative. We went to several sites, and there are several hospitals that have implemented the sepsis risk calculator and began doing some data reporting. For obvious and not so obvious reasons, we have turned to this self-paced toolkit, but our goal on the bottom bullet there remains to provide support and structure so every Colorado birthing hospital can implement the recommendations from the 2018 clinical report. And next slide. This is a key driver diagram. It's one of several resources that is on the toolkit. You can personalize this to your local center if it's helpful. It's a good quality improvement tool. And then next, Melda Music is going to present the success of implementation of an antibiotic stewardship initiative and sepsis risk, the sepsis risk calculator at Platte Valley Medical Center. Thank you.
Hi, I'm Melda. I'm a neonatal nurse practitioner. I currently work at Greeley Hospital in Greeley for university, but I've spent many years at Platte Valley, and so this is a great success story. It all started in 2014. Next slide, please. When one of our NNPs recognized the inconsistency practice between the providers, all neonatal nurse practitioners and pediatricians. And so she took that upon herself and took it to the special care working meeting, where there was a lead-in and pediatric representatives from both pediatrician groups that are at PLAT and the perinatal administration and a neonatologist. So she worked with the neonatologist, Peter Hulak, at the time, and developed a sepsis policy based on the 2010 and 2012 guidelines from the AAP and the CDC. And she developed this policy for 48-hour stay and postpartum for most well babies, and it also included a sepsis workup and more frequent vital signs. Next slide, please. So with this protocol, there was 3 levels of screening criteria based on the recommendations from 2012, and they used this to determine the length of stay for the babies, whether they needed to go to the special care nursery or whether they needed to go to the floor. Most well babies went to the floor, but if they went to the floor, they had a CBC, they would have a blood culture, they would have more frequent signs, vital signs. And but the pediatricians were all on board, and so they approved it. And we went out and we did education for all the staff, and we decreased our antibiotic utilization rate by 58%, a big number. Next slide, please. So in 2016, this is when we joined the Colorado Antibiotic Stewardship Collaborative and Von Oxford, and that gave us some real data. We started collecting about the pediatricians, how often we were giving the antibiotics. We did retrospective studies, and in 2016, we all of a sudden had all these inconsistencies in practice. Why? We thought, oh no, what happened? We had a lot of providers. Each of the providers brought in their own way of treating, and the inconsistencies all came back. So we went again and we started doing education again. Next slide, please. And we developed, joined the Vermont Oxford and the CAST team again, and we chose a key diagram like Mary used before and a SMART aim, and we started developing a big change and process. How are we going to get our antibiotic utilization rate down again? So with administration support, the perinatal director support, perinatal administration support. Our neonatologist at the time was Sadie Huyen. With her support, we had a pediatric champion, which was Don Dykes, and the NNP team, and then the nursing team, and also pharmacy. They all supported us, and we worked together to begin change. Next slide, please. So we educated everybody on our current sepsis policy, and we also took it to the pediatricians and said, you know, the pediatricians were ordering some 3 days, some 5 days, some 2 days. It just depended on how the baby was acting, but there was no consistency again. So we took those data collection points that we were looking at, and we took it back to the pediatric section meeting, and we also took best practice used from the CAST team. People like Mary Laird helped us define more evidence-based practice, and we came up with, you either stop antibiotics at 2 days or 7 days. So then it became more consistency, and that it was based on the blood culture and sometimes on the clinical appearance of the infant. But we decreased our antibiotic utilization rate again by 14% overall that year. Next slide. So this slide right here is kind of busy, but it kind of tells you our story. You can see at the beginning how high our antibiotic utilization rate was. And that's when we were admitting most of the babies based on if they had choreo, even if their placenta was positive, they might get treated for 7 days of antibiotics. And then after the guidelines were implemented, you could see where it starts to drop down. And we did really well. And then you can see in 2016 where it starts to go up again. And this is a time we joined Von, and we really looked at how we were doing, and really focused on our sepsis protocol. and really worked on educating the staff, defining our key guidelines, our key diagrams, and what our aim was to decrease antibiotic usage when it didn't need it. And our length of stay, we even developed a hard stop for our antibiotics instead of just letting it go on. So it automatically at 48 hours, you had to decide whether does this baby really need antibiotics because it was going to stay, or you had to reorder it. So that was a really good thing. We also looked at our blood culture results, and we were doing a lot of blood culture and CBCs out on the floor. And so then that brings us to the sepsis calculator in 2018. And at that point right there, we saw that we still needed a change. And what could we do to make things better? And so the sepsis calculator, really, Mary defined the difference between the sepsis calculator and our stratification that we were using before. And the sepsis calculator is so much easier to use. So we started that. Next slide, please. And what we found is that it not only empowered the pediatricians and gave them a way to look at things and define things, but it also empowered our nursing staff because they were able to use their critical thinking skills, whether the baby was well appearing, equivocal, or critically ill. It helped us drive the care that we needed. If the babies were critically ill, they would go into the nursery and we would monitor them, and they're going to get into more of the sepsis calculator and how to use it later on in this talk. But it was just an excellent tool, and it was so easy for our team to use. It also gave the nurses an SBAR tool to communicate with the providers if they needed to. If the baby was clinically ill, they were able to use the color system to talk to the physicians, and that was a great tool as well. It also gave us an opportunity to develop some tools when for handoffs, so that would be passed on, so that the nurses would be able to watch that 24-hour period for the baby well appearing, equivocal, or critically ill if there were risk factors. So it ultimately led to that babies that needed antibiotics received antibiotics, and those that did not need antibiotics were not exposed, leading to a successful antibiotic stewardship quality improvement project. Next slide, please. So this is our, very similar to the last slide that I showed you, run chart. But if you look down here at 2018 going on to 2019, and it continued to stay low, and the consistency of the group was so much better after the implementation of the sepsis calculator. It was easier to stratify, and it didn't get missed because nurses checked that off at when they were doing transition and when they were giving report to the next shift. Also, it also allowed for the pediatricians and the nurse practitioners to communicate what the sepsis calculator was and what this baby's risk factors were as well. So this was a great success story. The tools that we used are on the toolkit that Pam is going to go into. And I believe that Pam Zakhar is next. And she will be going into the antibiotic stewardship toolkit orientation. And please utilize it as much as you can, because it's really why we have been able to drop our antibiotic utilization. Thank you.
Great, thank you, Nelda, for that terrific story, real life use of these resources that I'm going to go through. I'm going to start sharing my screen now. There we go. Hopefully you all can see that. I'm going to be talking for about 10 or 15 minutes to orient all of you to this neonatal antibiotic stewardship toolkit that we have developed. And as Melda said, the resources that are in this toolkit are resources that steering committee hospitals used in their own centers that helped them to create very successful antibiotic stewardship projects and reduce the inappropriate use of antibiotics. So we hope that this will be very user-friendly and that you all will be able to implement these tools at your own hospitals. So in terms of finding the toolkit, the first thing that you do is go to the CPCQC website, which is easy to find if you just type in CPCQC in your browser. And on the homepage of the CPCQC webpage, you'll see toolkits and resources. And if you hover over that, you can click on antibiotic stewardship for neonatal early onset sepsis. And that will take you to the homepage. So what I'm going to do is kind of scroll through this toolkit. I'm going to open some of the links, but not all of them. And if there are questions at the end of all of the webinar presentations, I'm happy to go into some things in more detail. So basically, the homepage provides you background information, kind of similar to what Dr. Laird went through in her presentation about the why of antibiotic stewardship. This is information that could be used if you were starting a project and needed buy-in from either hospital leadership or from your staff in terms of providing background support for why this is something really important to work on. As you scroll through, you see that there are some links to things like references, and I'll show you, if you click on the links, it will actually, in many cases, link you directly to evidence, to papers. These all open in separate pages so that they can be just closed and you go back to the toolkit rather than having to back out. So scrolling down this background page, we have links to information from the CDC. We have a link to that 2018 AAP clinical report, and then just a little bit of information about CASC overall. So we emphasize here that, as has already been said, this toolkit is specifically intended to be used for infants in the first week of life who are 35 weeks gestation and beyond, and not for preterm infants. Right now, we don't have a link on this toolkit to the clinical report that from the AAP that focused on preterm infants, but that is something that we hope to add just for hospitals that are working on that population. There also is, in several places in the toolkit, but here on the homepage is one of these places, an email address, and any of you can send questions to this email address, and any of the steering committee members will be happy to answer questions. This one email address will link you to all of us. At the bottom, you'll see the names and the hospitals that the steering committee members represented while they were doing their antibiotic stewardship work. Some of the steering committee members are no longer associated with the hospitals that are listed here, but these are the hospitals for which they did antibiotic stewardship quality improvement work. So now I'm going to actually start walking through the different elements of the toolkit. And over here on the right in this gray box, we call this our navigation pane. You'll see the different sections of the antibiotic stewardship toolkit. The toolkit is intended to be used either for hospitals that just want to implement one or two interventions, or for hospitals that are actually creating a neonatal antibiotic stewardship quality improvement team and are trying to do take a more comprehensive look at their antibiotic use. As I click through the different sections, you'll see that they're all organized in kind of a similar way, and I'll describe what that is. You'll also see that there is some redundancy between sections because we didn't want for hospitals to have to click into multiple sections of the toolkit in order to find the resources that they needed to work on whatever specific element of the toolkit they were working on. So I'm going to spend the most time on the sepsis risk calculator toolkit element because it sort of mirrors the other sections, and I'll walk you through those resources. So you click on each element of the navigation pane and it'll take you to a new page. So this is the Implementing the Sepsis Risk Calculator page, and all of the different sections have a background and resources section at the top. So this is background information about the sepsis risk calculator. We've got the AAP clinical report. We also have a direct link to the sepsis risk calculator, which is handy. And I think it's already been said, but this is also known as the Kaiser Neonatal Sepsis Calculator and the Early Onset Sepsis Calculator. Those all indicate the same tool. We've got some other resources that describe the development of the calculator. So this first resource is a fantastic handout. It's a PDF from a pediatrics medical group conference, and Dr. Puopolo, who helped to develop the sepsis risk calculator, gave a really nice talk on how it was developed, which could be helpful if your team is trying to decide whether or not you want to implement the calculator. There's also a webinar that was developed by the Perinatal Quality Collaborative of North Carolina. And you can click on this link and view a recording of their, they sort of do a Kaiser calculator demonstration. And several of the other perinatal quality collaboratives were very generous in offering to share their resources. And so there are a couple places on the toolkit where you can actually link to other neonatal antibiotic stewardship collaboratives websites, and they have said that people are free to use their resources as well. The next section in this part of the toolkit, which is also you'll find in the other parts of the toolkit, is implementation guidance from steering committee members. What we tried to do is ask some of our steering committee members to provide guidance about what worked at their site. We have, first off, a handout that was provided by Melda Music and Carrie Montgomery that compiled some information at their center for some of the things that helped with their success, specifically at implementing the sepsis risk calculator. We also have some quotes that sort of describe people's experience here. And we have a handout that is modified from a handout that was provided again by Dr. Puopolo, but was added to by steering committee members based on our experience with questions that have been frequently asked about how to fill out some of the fields in the sepsis risk calculator. So I'll just open that quickly, and later on, as folks are giving more of an orientation to the calculator, you'll understand what these fields are if you haven't already used it. But this gives some valuable information about how to fill out some of the fields that are a little bit trickier, and that can be used to educate staff. The next section here actually provides a couple of sample guidelines for early onset sepsis that integrate calculator use. We thought that these guidelines would be very helpful for hospitals that are trying to implement the calculator. And so the first is a guideline from SCL Health. And the second is actually kind of a template for a guideline it was created by some providers at Memorial Medical Center, and Dr. Laird provided it to us. And it actually, it encompasses calculator use as well as some of the other antibiotic stewardship best practices that can be implemented outside of the sepsis risk calculator. So I'm going to pull that up really quickly. This could actually, it's a sample guideline that could be modified by centers, and it also integrates some sort of educational information and tips along the way. So that's a very nice resource. The next section is about information about neonatal blood culture collection. And this section was created by Dr. Bobby Chambers-Hawk. And it is a really nice handout with education about how to optimize blood culture collection, which is obviously really critical to any antibiotic stewardship effort, since you have to have reliable blood cultures in order to be able to feel confident about stopping antibiotics. And that handout also has a link to a video, pardon me, that was created by the Perinatal Quality Collaborative of North Carolina that also provides education about optimal blood culture. And then the final section here of this part of the toolkit, which is repeated in several of the other elements, is some support for data collection. And so what we've got here are 2 Excel templates, and I'm going to open one of them, that if your center wanted to collect data, for example, on antibiotic utilization rate, you could download this Excel template that was created by Val Garrison, who's the Director of Initiatives and Engagement at CPCQC. And it's a really beautiful template, has instructions, and then a place that you actually put in the data for antibiotic utilization rate. And by doing that, it'll spit out for you one of these really beautiful run charts, like what Mary Laird and Melda Music showed that their hospital team used. So this is really a terrific resource if you want to do a data-driven quality improvement project. We also, above that, we have a similar run chart that was used at Platte Valley Medical Center to audit whether or not the calculator was actually being used as it was intended to be used on every newborn. And so they found that to be a handy metric to determine whether the calculator was actually being used as they intended it to be used. We have a nice handout that was created by Jeff Homan, one of our steering committee pharmacists, and was with assistance from Scott Sveum, one of our other pharmacists, that walks you through the antibiotic utilization rate and how to get those data and what it is. And then finally, there is a case review guide. So any team that's thinking about doing an antibiotic stewardship project, in addition to collecting optimal blood cultures, also should be paying really close attention to cases of true sepsis and reviewing those cases to make sure that any of the interventions that were introduced did not result in delayed or completely missed cases of sepsis. So we've created a structured way to do a case review if you have a positive blood culture in the first 7 days of life. So I know that was a really quick sort of going through a lot of information from that implementing the sepsis risk calculator tab. I am actually going to just quickly go through a couple of the other tabs, but I'm not going to be as comprehensive. And so the next section is called Implementing Other Neonatal Antibiotic Stewardship Best Practices. And these are some of the things that Dr. Laird went through in her talk. But we've got resources to help you if you want to create an early onset sepsis guideline. And so again, we've got these sample guidelines that you could use. We have information about optimizing neonatal blood culture collection, antibiotic choice and dosing, including some references that are recent for that. And then some implementation guidance on standardizing antibiotic courses, which Melda talked about was very important for their project. So the AAP recommends shortening courses to 36 to 48 hours with negative blood cultures. And so we have some guidance about how other centers were able to do that. And then again, the same data collection resources here as we had on the sepsis risk calculator section. The next part of the toolkit is a little bit more general and talks about how you might create a neonatal antibiotic stewardship QI team. And this pulls in resources from the CDC. It also pulls in resources from the Pediatric Infectious Disease website. And we have, in terms of implementation guidance, some of the tools that were used by our CASC hospitals when they were working on the Vaughan Collaborative, including templates for creating a project charter, which is sort of like a roadmap that your team would use to say who was going to be on the team, exactly what you were going to try to do, and what interventions and what measures you were going to collect. We also have a charter that has sample answers on it for clarification. We have, again, a link to the key driver diagram that Mary Laird showed in her talk. And we also have, as I mentioned, some links to some of the perinatal quality collaboratives from other states that have agreed to share their resources with us. And then we have the same data collection section, except for on this tab, it's quite a bit more expanded. So for teams that are really focusing on data collection, this has more resources. Okay, so the next two sections I want to highlight just quickly. We created a tab for teams that are interested, if there are pediatricians on the team that are interested in receiving maintenance of certification Part 4 credit through the American Board of Pediatrics. This project has been approved. And so if physicians are on teams that are working on projects, they don't need to pay anything. All they need to do is follow the steps that are outlined below and actually submit certain information to CASC through this email address. And we will fill out an attestation and the credit will be awarded. There is a similar process for family physicians. They can receive performance improvement credit for their American Board of Family Practice, but in this case, it has not been pre-approved. So you would just submit directly to the American Board of Family Practice. And finally, even though this is the last tab I'm gonna show you, it is a really important one, which is we've pulled together a lot of resources about how to engage and educate families who are such important partners in working on any quality improvement initiative. And so we've pulled together a bunch of different resources, handouts, and videos that can be shared with families. So that is really the toolkit overview. And I think the next section is going to be Tracy Heberlin, who is going to be talking about the sepsis risk calculator in more detail.
Hi there. Thanks so much, Pam. My name is Tracy Heberlin. I'm a neonatal nurse practitioner, recently retired, so one of those no longer at one of the sites. And my journey with antibiotic stewardship began in 2015 while I was a chair-elect for the Colorado Perinatal Care Council. At the time, the Vermont-Oxford Network and the CDC invited states to enroll hospitals to participate at a discount in their Choosing Antibiotics Wisely quality initiative. And during this time, the SRC was just developed and was undergoing further validation as a sepsis probability tool. Next slide. So using a Bayesian approach and a base population of over 600,000 newborns, Guapolo and her team developed two linked prediction models for neonatal early onset sepsis. The first model establishes a newborn's prior probability of EOS based on gestational age, highest maternal antepartum temperature, GBS carriage status, duration of rupture of membranes, and the nature and timing of intrapartum antibiotic administration. The second model qualifies how the baseline risk is modified by the infant's clinical exam. The online calculator created embodies both of these linked prediction models. Next slide. On these graphs, you can see the most sensitive indicator of EOS is highest antepartum maternal temperature. It's followed by gestational age, and then the duration of rupture, timing and type of antibiotics, and then the mother's GBS status. The last two are much less sensitive predictors of the EOS. Next slide. So benefits of the sepsis risk calculator: it positively impacts the future health of newborns and future effectiveness of antibiotics. It improves mother-infant experiences. It uses sensitive indicators to reduce unnecessary antibiotic exposure and increase care consistency. It eliminates the need for subjective use of less sensitive and specific screening tools for decision-making, like CBCs and CRPs. And it reinforces that well-appearing babies have a high probability of being well. Next slide. So the who, what, where, whens, and whys. Let's start with the why. And the why is to safely identify newborns at risk for sepsis and assist in directing increased surveillance, further evaluation, and treatment for those with a high probability of illness, and thus decreasing unnecessary antibiotic exposure. We're going to perform it at once by about 2 hours of life, ideally early in transition as the data points become known. What we're going to do is we're going to determine the EOS risk as it's calculated with the SRC, either on a desktop or a phone, or if that's not available in your EMR. And the EOS overall and clinical exam stratified risk score is then documented. Risk and care needs are communicated with providers and staff for babies needing enhanced surveillance, screening, and or further care. Where we're going to do it, we're going to be doing it in the LDR or the operating room during transition and following birth for the earliest risk determination. And who? It's going to be the newborn birth attendant or the transition nurse completing the SRC. And they're going to complete it on all inborn neonates who are delivered at 35 weeks and greater. And they're going to be using the CDC National EOS incidence of 0.5 thousand per thousand live births. Next slide. Okay. So here we are with the calculator. This is the view that you would see when you pull it up on a desktop. And the calculator has 6 details that you need to resolve. The very first one is the baseline incidence. And we recommend using the CDC incidence of 0.5 per thousand live births, as most newborn care units do not have an adequate volume of EOS to determine their own incidence. Next, we're going to input the data points for gestational age, including the days, the highest maternal temp up to 1 hour after delivery in Fahrenheit or centigrade, the rupture of membrane duration, which you can round up or use decimal points for partial hours, the GBS status, and finally, intrapartum antibiotics, if any. You'll see there's blue bubbles on the left next to each of the variables, and that's kind of a hover and discover that you can click on for more information about that data point. Once the data is inputted and completed, you click on the blue tab to calculate. It's on the right on the web page and below you on the phone if you're on a phone app. It will give you the overall risk and then the risk after clinical exam. So note that the recommendations and vital signs are color coded. These colors go along with the sepsis risk. So green, an early onset risk of less than 1 per thousand live births, indicates low risk and routine care. Yellow is a risk of 1 to 3 per thousand live births, is cautionary and may recommend blood culture and enhanced vital signs. Red is greater than 3 per thousand live births, and it's a high probability for sepsis and suggests or recommends empiric antibiotics, NICU care, depending on the clinical situation. Some institutions have staff document the risk and treatment recommendations based on color. To make sure you apply the equivocal and clinical illnesses consistently, we're going to click on a classification for clinical presentation to review exam findings for the well-appearing equivocal or clinical illness. And you'll notice that that's right below the red of the empiric antibiotics. So let's go to the next slide. And here you will see that the well-appearing and the clinical illness categories are pretty straightforward. An equivocal exam allows for 1 physiological abnormality for 4 hours or 2 physiologic abnormalities for up to 2 hours. Next slide. So we're going to do a couple scenarios with the sepsis risk calculator. So let's try a case and we'll enter the data together. So Val has pulled up our calculator, and let's go ahead and enter our scenario 1. I would love everybody in the audience to go ahead and pull it up on your phone or your desktop if you can. I believe that the address will have been sent into the chat as well, or you can just put in, if you put in EOS risk, it'll come up as the first one. So now that we're on scenario 1, we've got a 25-year-old who presents in active labor. Let's got the CDC incidence of the 0.5. We're 39 and 0, max temp of 98.5, rupture of 5 hours. GPS is negative, and there's no intrapartum antibiotics. And we'll go to the next slide, and you can scroll down too, so that you'll see here, both the well appearing and the equivocal are in green. That's routine care. The clinically ill has a strongly consider, but does not recommend antibiotics, as there really are no risk factors in this case. This is where mode of delivery or other maternal factors could influence your decision to wait on antibiotics. Maybe this was an induction for PIH on magnesium or a scheduled cesarean without labor for an IDM. Whenever a baby is clinically ill appearing, antibiotics are always strongly considered, if not firmly recommended. So Val, we're going to go ahead and play with the calculator, and we're going to adjust temperatures and see how a fever adjusts the probability in a term GBS negative mother. So let's go to 100.4. And then we'll go ahead and calculate. And then you'll see that 100.4, an overall EOS risk is 0.52 and the well is 0.21. However, it does shift the equivocal to yellow because it's in between 1 and 3. So it's at 2.58, and it recommends heightened surveillance and blood culture, but no antibiotics. If we roll back up and put in 101, you'll see that both the overall early onset scores and the well are still below 1, but it shifts the equivocal to red, where empiric antibiotics are recommended. If we were to go up to 102 and calculate that one, you'll see that the overall score goes up to 2.07 and per thousand live births. The well is still below 1, the well appearing, it's at 0.85. But this shift of the well appearing goes into yellow, but we're going to do some heightened surveillance on that. Where was I on this? I wanted to show you that if we go up to 100, it takes us to get to 103.5. Oh, I'm sorry. Before you do that, scroll back down. My point was on here that, and go up just a little bit, that our indications, clinical recommendations are based on, in the well appearing, are based on the overall risk score because it's between 1 and 3, even though the well appearing is less than 1. So I wanted to point that out there. Now let's go back up and do the 103.5. And that's what it took to actually get a well appearing to have empiric antibiotics. But that temperature just shows you how much you can drive the calculator there. Okay, let's try one more. I think we got time for one more. Scenario number 2, we're in that 0.5 per thousand. We've got 36 and 3 and a max temp of 100.2, rupture of 5, GBS unknown, and the mother given amp every 4 hours for 12 hours. Let's go down and calculate. And I'm curious how many people actually got the 0.31. If you actually got 0.36, you would be correct because you would have selected GBS specific rather than the broad spectrum antibiotics greater than 4 hours. So when we change to GBS specific to greater than 2 hours, which our Val can go back up and do that, the overall risk does go up slightly to 0.36 in this case, but the recommendations remain the same. So let's say this mother did not receive antibiotics. Val, can you change that to no antibiotics, please? And then the overall EOS risk goes up to 1.02 per thousand live births, and the equivocal jumps to 5, indicating empiric antibiotics. This, I think, is really the only tricky tab. So we got to pay attention to both the timing and types of antibiotics, be it broad spectrum or GBS specific. And as Pam had mentioned earlier, there is a frequently asked question link on the calculator that will help with up-to-date information on what intrapartum antibiotics that are used for prophylaxis are GBS specific or not. Okay, next slide. Oh wait, back on this one, just goes to show you that well appearing at 0.42, well appearing infants, even in this case of late preterm, unknown GBS status and no antibiotics, the baby's risks remain low at 0.42 per 1,000 live births. Next slide, my final slide. The SRC is a validated tool that allows us to use sensitive EOS neonatal sepsis indicators together as an objective lens to look through when making the decision to administer antibiotics to newborns. And because it gives us a value for the probability of sepsis to base our antibiotic administration on, we no longer have to say to parents of well-appearing babies, which over the years, I've said it many times, that we don't know whether your newborn is infected or going to be infected. So we are going to look for infection and start antibiotics until we can prove otherwise. And I haven't had to say that since the calculator, because well-appearing babies don't need it for the most part. Next, we're going to have Scott Spham. He's going to share, he's a pharmacist from St. Joe's. He's going to share how St. Joe's has incorporated the SRC into their workflow and integrated it into their EPIC electronic health record. Thanks. Go for it, Scott.
Thanks, Tracy. Yeah, I'm Scott. I've served on CASC as a student committee member and as a vice chair for 6 years. And as Tracy mentioned, I was previously at St. Joe's for 22 years, at which time I was in oversight of pharmacy services on women's care and the neonatal intensive care unit, and was involved in many quality improvement projects. I know back in 2016, when we were in the throes of kind of implementation of the sepsis risk calculator, it occurred to us, gee, it would be nice if we could kind of see what other hospitals that may be involved in this were doing and kind of get a peek under the hood at that from those guys. And so you've heard a lot today about kind of why the use of the calculator is very important and some great scenarios about how it was implemented. But I just kind of, this is not really a how-to talk, but more of just what worked for us at St. Joe's. Next slide. So what we did is a nurse-driven protocol. At St. Joe's, we have 4,500 live births, the largest birthing hospital in the state of Colorado. And we have a team of transition nurses. Not everybody knows a transition nurse is a nurse involved in all day long, basically just transitioning a baby from an intrauterine to an extrauterine existence. And we determined that that would probably be the best core team to kind of make a sepsis risk calculator. They would be the best to kind of do the first evaluation and to kind of be able to take it from there and make it a nurse-driven protocol. And I'm very proud of the fact that Karen Cayley, for all the RNs on the call today, she won the Nightingale Award. It's the highest award given to any RN in the state of Colorado every year, just one nurse, and she won it based on the results of our project that we did. So we had some great results. And I just kind of want to talk about it a little bit from the nuts and bolts and how it looks as a day in the life, and maybe a little bit about, we use EPIC and what it looks like from that technical platform, and may or may not apply to your use, but just as an idea. So again, it's EPIC-based, but go back a sec, Val, please. It is an EPIC-based documentation system that we used. And we built the custom flow sheets initially because it didn't exist in EPIC. But since then, the EPIC Foundation platform does include the sepsis risk calculator in the flow sheets. And so for those of you familiar with flow sheets and use in EPIC, you can acquire that. So now we can proceed to my next slide. Thanks. So, you know, a baby is born at St. Joe's. It's going to be a very similar picture to what happens at your place. We're going to do Apgars and skin to skin, but that's typically the time at which the transition nurse is going to do some kind of documentation and kind of an evaluation of the baby. And for it to work so that you can calculate, have the calculator work in your EMR, whether you use EPIC or not, it's important that there is some kind of a link between the mother's chart and the baby's chart, obviously, since we're pulling data from both patients. At St. Joe's, if a mom is registered to 4125, then our baby is in N4125. That's how the link works in EPIC. for us to pull the data both. But this is just a neat screenshot of the neonate, but you can see that the maternal summary and the link to the mom's chart appears, and this is how the data is pulled. You could do this either way. You can even do it on a paper system, of course, but this is just, again, an example of how we do it at St. Joe's. Next slide. Because of the fact that we have many different provider groups that have privileges to work at St. Joe's, one of our implementation barriers was the fact that there was a lot of different opinions about how we should use the sepsis risk calculator. And we've referenced Karen Poplow a couple of times. I know at her talk at Vermont Oxford a couple of years ago, she suggested that when she first pitched the idea of the risk calculator to her colleagues, she was literally laughed in her face. They said, this isn't a possibility even. And so given that, when we were in the throes of implementation, that was one of the barriers we had as well. And admittedly, we don't use the calculator exactly as you will see it in Tracy's examples or as it is on the Kaiser link. We kind of have a little bit of some differences that I can talk about here, one of which is the fact that we round our ruptured membranes up to the next flow hour, and we look at vitals at the 2-hour mark initially as well. But you can see in this screen, it's kind of neat, is the fact that the maternal temps that are out of range would be highlighted and then they'd be pulled into the flow sheet on Epic. And one other point that I always like to make is the fact that equivocals in our workflow are not always transferred to the NICU. So that's more of a nurse practitioner or a neonatologist call based on the clinical picture of the neonate to decide whether or not that baby goes to the NICU. So our equivocals can kind of go either way. Next slide. So this probably looks very familiar to you after Tracy's talk, and if you've used the calculator at all, it's just the Epic version of it, of this Kaiser Sepsis Risk Calculator. This is the Epic version. And so once all of the data is put in by the transition nurse, it flows into a flow sheet, and you can see you have the well-appearing equivocal and the red section. And this is just a report that gets generated. Our transition nurses do a progress note, and this screenshot and all this data flows right into their note, and the providers can do the same as well. And I think I already commented on the different provider groups. Next slide. And this is just not unlike what Melda presented, but this is just kind of our results page. And the PDA cycle number 4 is the point at which we implemented the use of the calculator. And you can see prior to that, it was, very high variability in our antibiotic use rate. We thought we were doing okay. We were actually at or slightly below the Vermont Oxford national averages, but through the use of the calculator, we were able to improve our antibiotic use rate pretty dramatically. And as you can see too, our control limits are much more narrow on this run chart, and you can see that our results have been very consistent thereafter. So I don't want to really make a really long, this is just a short discussion about how it could look if you were to implement it the way we did at St. Joe's. So I think that's all I really have. I think our next section in today's talk is going to be more of a Q&A and discussion. So I think it's open to all the panel members for any questions you might have. Thank you.
Thank you, Scott, and thank you to all of our presenters. There's a wealth of information in this room right now, and so I just want to call out, Mary chatted out to the attendees, so please ask us any questions that you have. In her words, we are SRC nerds, and we would love to share with you. So, there's a lot of passion for this work. I do want to comment on 2 things before we open up for discussion. The first is when you close out this webinar, you will see a web-based window pop up with our evaluation survey. We would love your feedback on this, both this presentation and the toolkit, and we want to hear from you of what other information would be helpful. The other thing is I noticed we had a little bit of an issue with screen share previously, so I just wanted to share one resource, reshare that, which is the annotated run chart template. Can you all see this Excel file?
Mhm.
Okay, great. So Pam, I don't know if you wanted to talk through it or if you want me to just orient to it.
Go ahead.
Okay, so as you'll see, there's an instruction page which will tell you how to use the template and which columns to fill your data into. Here is where your data will go. You'll enter your antibiotic days and your patient days into the blue columns, and the AUR will automatically calculate for you. And then for what will happen is all of this data will auto-populate into the run chart. So you don't have to make the chart, you can just look at your data. And then you'll see, you'll notice that our median changes at a certain point because we put in some key things that we noticed in our data. And so if you're unfamiliar with run charts, you can go to the rules for interpreting charts, and you can learn a little bit about how you test a change, how you identify signals in your data that might say, you know, something is happening here, whether it's a one-time event and you can identify, oh, that's an outlier, we can ignore it. Or maybe you start to see patterns in your data that indicate that your average is changing. And so again, if you need any help with interpreting this data, you can email us at info@cpcqc.org and we can help you with this resource. So I just wanted to call that out, and I will go ahead and close that, and we'll go back to opening it up for questions and discussions. So we would love to hear from you. And at this point, you're welcome to come off of mute.
This is
Oh, I'm
Mary
not.
waiting. Oh, does
Oh.
somebody have a question? Yeah, go ahead.
Oh, Mary, this was Tracy. I was just going to ask, I was curious if any of the participants would want to share where they are in their journey with either using this SRC antibiotic stewardship in the newborn. I'm just kind of curious, those that are here, if any of them have worked a lot with it or are trying to get it implemented. And I guess, Val, I'm not sure if they can answer only by going through the chat.
No,
I'm sorry. Maybe I can't ask a question.
I just gave everybody the ability to talk. So
Okay.
You can unmute yourselves if you have.
Okay.
I guess we've done a wonderful job and there are no questions in the room.
Well, people are maybe thinking, and we really would love to hear, and also would love to know how we could help if you're finding obstacles in your centers about implementing the sepsis risk calculator. So do let us know. But I was going to comment that, you know, I feel like I know a lot about this topic, but Tracy, I don't think that I realize that the baseline rate impacts the recommendation for the well-conditioned infant. This is new information for me, and I believe that is true. That's pretty cool. There have been a few questions that have come up through the years about the recommendations from the sepsis risk calculator. One has been, do babies still need to stay 48 hours if their mom was group B strep positive? And although I feel like I have an answer for that, does anybody have any thoughts or inputs about that? As Tracy pointed out, the group B strep status is has the lowest predictive value of a baby's risk of infection. And I don't think that actually the clinical report, the 2018 clinical report, even comments on that, although I have to go back and look at that, but that's my recollection about that.
I do want to bring up another common question that often comes up is which antibiotics are included in the broad spectrum, and kind of that decision making and how to collect that data and who to count.
It might be helpful to pull that frequently asked questions handout up. And then,
I'm going to stop my screen share for a moment so I can pull it up quickly.
do you want me to do that?
If you already have it up, that would be great.
Yeah, sorry. I'm going to share my screen. Okay, and so, Mary, I don't know if you want to comment on this.
Sure.
I created that here.
The recommendation about group B strep antibiotics is most clearly identified in an early 2019 paper, also by Puopolo, who says although vancomycin and clindamycin are used in penicillin allergic moms, only ampicillin and cefazolin and penicillin are considered group B strep specific antibiotics. The others are considered either when they're used by themselves, neither broad spectrum nor group B strep specific. Now, it's very possible and very likely that giving those medications actually do impact the baby's actual risk of sepsis. But from the standpoint of entering them into the calculator, she's really specific about only counting those. I wouldn't be surprised if that guidance changes over time, but that's a specific recommendation. And then the broad spectrum recommendation comes from the 2017 recommendation from ACOG for the treatment of intrapartum or intrauterine infection during labor. And there are a few others that meet the criteria appear in broad spectrum antibiotics generally defined, and then it has some specifics. I think I found in our OB guideline that mefoxatin was used, and actually scroll back up just a little bit, Pam. Yeah, right there, yeah. So cefoxitin standing in for cefotetan, but that 2017 paper is in, I think is linked to in our guideline as well. I think it's also referenced at the bottom of this FAQ. And to further talk about that issue, the basic build for EPIC for the sepsis risk calculator gives you some helpful guidance about what to put in into some of the fields, but it's actually not accurate on that group B strep specific antibiotics thing. And actually at the UC Health level, we are looking at changing that, and the EPIC people are going to help us make the correct changes for that. And I'm sorry, one more thing. Actually, Tracy ran through the scenario of group B strep specific versus no antibiotics, and it does make some difference in the ultimate risk of sepsis and sometimes the recommendations.
Great, thank you. So I'm going to pause for a moment to give others a chance to ask any questions that might have come up. Okay, so with that, I want to thank all of our panelists today for pulling this together and presenting some great information that's really helpful for these teams. And so with that, thank you all for joining us. Please remember to complete that evaluation survey when you close out the webinar, and have a beautiful day.
Thank you all. Are we still recording?